pick up the steak knife to assist the former President of the United States to cut his steak. Out of nowhere, a Secret Service agent is in my face. We're talking right whispering level, and you'll allow me. He goes, "Dr. Nash, put knife down." I'm terribly sorry for the profanity, but so what did I do? I put the knife down, and Mrs. Ford, not skipping a beat, unbelievable, she says to me, "David, pass me the president's plate. I'll cut his steak for him." That's my major memory of that meal. Is that incredible? That's a great Jerry Ford. So you can't make that up. Thank you. Thank you. You can't make that up. It stuck with me for 15 years. Okay. But back to the business at hand, not nearly as entertaining, but way more important. So you got to trust me, these three silos, they don't like each other. The measures make no sense. There's too many of them. And part of our challenge, most especially for your medical leadership at the ground level, is to translate all of this into a way that does make sense and to build your measurement systems to meet this sort of challenge. Okay. So how are we doing across the country? Here's my transition slide. If you can't read the caption, it says, so does anyone else feel their needs aren't being met? Okay. So you know all this. You know all about non-payment events. For the first time, hospital chief financial officers give a rat's ass about what's going on clinically. They're in the ER asking all kinds of questions. Did that post-MI patient get the appropriate dose of beta blockers pre-discharge? They have no idea what it is they just said, but they know that there's an economic consequence to that clinical decision-making. Now, we could quibble if Bob Wachter were here or Peter Pronovost were here. We could get into fisticuffs about, are these the right measures? Are these never events the right ones? Is readmission an appropriate measure of quality? You know, folks, it doesn't much matter at this point. That horse is out of the barn. Our job now is to sort of sort through these measures, make sense of them, work together to figure out, well, what is the best way of practicing based on the evidence in a patient-centered way right here in Grand Rapids. That's our challenge. Incredibly hard to do. Most doctors don't have the skill set to even begin to ask those kinds of difficult questions. Why? Well, simple. We were never taught. Not on the curriculum. For most of us. Now, when you build your new school, you got to add that to the curriculum. So let's take a look at this. Well, so how are we meeting these challenges? Well, Pennsylvania, again, you might remember, not even 4 years ago, published the first ever book on hospital-acquired infection. This book caused sort of a national stir. It ended up on the front page of the USA Today. Pennsylvania reveals infection rates in hospitals. Do you think that USA Today ever would have written a story about hospital-acquired infection rates without the publication of that report? I don't. So here's the connection. Mandating public accountability and transparency is going to bring with it all sorts of attention at a pretty granular level of what it is we're doing. Are you ready for a report card that lists every hospital in your system and their hospital-acquired infection rate? It's going to be up on healthcare.gov pretty soon, as well as your central line-associated bloodstream infection. I mean, we could drill down into some incredible level of detail. By the way, when we published this 4 years ago, what was the variation across the great Commonwealth of Pennsylvania? Well, Allegheny General, where Rick Shannon had been working on this for 2 years, had a 0 hospital-acquired infection rate, and Thomas Jefferson University Hospital, next to the country's largest private medical school, had an 8% rate. We didn't even know what our rate was till we read it in this report. Why? Well, no one had ever measured it before. Now, we've improved dramatically in the 4 years since this report was published, but you get the idea. This is going to require unbelievable teamwork, data gathering, working together to sort of sort this mess out. Now, here we are at the National Press Club. Here's the cover story on modern healthcare. Here's another way of looking at this, all within the accountability arena. So Judy Hibbert and her colleagues have been studying medical report cards. You're familiar with the last 2 decades of report cards. And Judy, who's super smart at the University of Oregon in Eugene, she talks about something that I really had to understand. And she says, well, consumers understand report card best when it is succinct, okay, I get that, and conveys a message of risk, not benefit. So most report cards, if you've been in this business, you know we talk about severity-adjusted morbidity and mortality. Most clinicians couldn't really explain what the hell that is. So the public, that wisdom of crowds again, the public says, well, we don't care about severity-adjusted morbidity and mortality. Here's what the public cares about in a report card. How safe is my hospital? And stuff like this. How to avoid a fatal hospital mistake. Now you know why sex only gets better. That's an important topic too. But this is where we are when you actually ask Joe and Jane in downtown Grand Rapids, what kind of information would they like? They want to know, am I going to get an infection that I didn't deserve and didn't have when I get admitted to Jefferson or to a Spectrum hospital? That's what the public is asking. And then you're going to see stuff like this. So read in the upper right. Choose a hospital with fewer mistakes, complications, and deaths. Whoa. Well, that's something anybody can understand. Severity-adjusted morbidity and mortality, what the heck is that? So one more time, transparency, accountability at levels that we've never really seen before. Here's another level of transparency and accountability. Patty Spaeth's amazing book, Partnering with Patients to Reduce Medical Error. And we'll skip this one. David Shulkin's book, Questions Patients Need to Ask. What's the theme here? Well, we're seeing a whole genre. Remember that chart about accountability, then consumerism, and then crossing the quality chasm? Remember that? Well, we're seeing a whole genre out there of books and material at the patient level, asking patients to participate more in their care in both the inpatient and outpatient setting. So what do you think is in a book like this and a book like Shulkin's? What sorts of stuff would fill a whole book? Well, Chapter 1, ask questions. Chapter 2, have an ombudsman or a family member with you. Chapter 3, nothing about me without me. Chapter 4, take notes. I mean, you get the idea. That empowering patients to participate in their own care, well, that sounds spectacular when you're the patient. From a provider perspective, this could be difficult for you and me. This could be pretty tough. I mean, when patients come to my office with 15 pages they've printed out from the web, I think to myself, there goes my morning. So when we say patient-centered, what exactly do we mean? And how patient-centric do we want to get? And are you willing to be measured on your patient-centeredness as one of those 6 Institute of Medicine critical domains for the future? So, again, part 2 is just to give you a sense of what's going on around the country. Finally, when you build your new medical school, I hope you have a plan for a simulation center. Most of the doctors in this room, especially anybody over 40, you have no idea what I'm talking about. But at Jefferson and most other major medical schools now, where do students learn how to put in an IV, do a lumbar puncture, put in a central line, get a blood gas? On a mannequin. In a laboratory under controlled circumstances, instead of how you and I learned, which was what? On the poor and on people of color. That's how we learn. Of course, we didn't really think of it in those terms, but that's exactly how it went. So Bob Helmreich and Ashley Merritt are sort of the grandparents of this whole movement. This is the modern-day equivalent. I hope you've got to see John Nance sometime in your career. And the guy who is the ABC News airline advisor. Anytime there's a crash worldwide, John is on television. He's an amazing guy, and I can't do justice to his wonderful book that I got the privilege of writing the foreword to. But basically, this is all about the concept of crew resource management. And I know some of you are deeply involved in this. Learning how to communicate to improve safety. The punchline of all of this is Going against the authority gradient without fear of recrimination. Let me do that one more time. Going against the authority gradient without fear of recrimination. Well, this is incredibly hard to teach, especially in the hierarchical nature of what we do in the hospital and at the bedside. It's a very tough challenge. Okay, so let's talk about the future, and I'm watching the clock to make sure we'll end right on schedule. So let's talk about the future and the challenges that we have from a leadership perspective from both physicians and the board. And the reason I'm so concerned about this is right here. And I'm sure you feel similarly. So, of course, these are my fraternal twin 24-year-old daughters. That's Rachel and Leah. They are 19-year-old brother Jacob. I'm David, married to an Esther. You could figure out the rest. We're out of Old Testament names at this point. So I'm very concerned about the future for Spectrum and for